All right, here is some of those pediatric questions that I was talking about. Um, I do NCLEX style question dissecting for one of my other jobs. So these are kind of the questions that I go through with that group of students for pediatrics. So just a few questions. How would you think about it? What should you think about when you get in front of a test question? Okay. So this is a 3-year-old child admitted to the pediatric unit. Which should the nurse do to maintain the safety of the preschool age child? So here we go. Safety, number one concern. How are we going to keep this kid safe? A, teach the child how to use the call bell. B, put the child in a crib with high side rails. C, ensure the child is under continuous supervision. Or D, have the child stay in the playroom most of the day. Safety. So just talk yourself through the answers, right? Teach them how to use a call bell. A 3-year-old? A 3-year-old likes peekaboo. What's he gonna do? He's gonna keep calling on the call bell all day. Heck no. Tell mom and dad where the call bell is. Put the child in the crib with high side rails. 3-year-old. What kind of bed should they have at home by now? What's those high side rails gonna do? What's that track and field event? The high bar? He's gonna jump over those side rails, climb down them, and potentially fall and crack his head open. Stay in the playroom most of the day. The playroom is an infection control nightmare. The child is not going to stay in the playroom. At 3 years old, he's going to wander off. He has no attention span, right? I want to make sure that the child is under constant supervision. Safety needs are met if somebody is in the room. So somebody needs to be in the room or potentially camera. So we could put a camera in that room or put the child in a room with a camera. Okay. Needs to be constantly supervised. He's a one-on-one. Okay, next. The heart rate within normal limits for a 2-week-old baby. On these kind of questions, you typically may be able to take off the lowest number and the highest number because they're probably trying to trick you. If you did not know, right? But if you knew that a 2-week-old baby is similar to a newborn and the fetal heart strip monitor paper says 110 to 160 is normal, then only one of these would be correct. So normal limits for children after they get out, usually 120, 160. So the 172 would be too high. The 56 and 64 would be way too low. The question is, did you look at 2-week-old versus 2-year-old? Okay, so read the entire question. They're trying to trick you. They put in small ones in case you didn't read week-old. Read every single question. Read every single answer. Come back, reread 2-week-old newborn, newborn, newborn. Then come back down in the answers. Okay. What scoring system do we use to quickly assess aspects of the overall health of the baby at birth and ascertain whether he or she needs immediate medical help. What was that score called? Absolutely. APGAR score. APGAR score is that way of looking at, do we need to send this baby to the NICU or not? So the AIM score measures side effects of antipsychotic medication. The GAF score evaluates the extent to which patients' psychological symptoms impact their daily life. And the NAS is the neonatal abstinence score for withdrawal. Okay. Question 4. Cystic fibrosis. What do you know about cystic fibrosis off the top of your head? Thought process, something to do with the lungs, okay? But the question is, what are they asking me for? They're asking me for the treatment that enables the progress of secretions to go from small to larger airways for ensuring removal. So what is that called that I put them over my lap and I cup the bottom of the lung to the top of the lung, trying to get the secretions to move? What is that called? So you can do this manually or you can do this with a machine. They love to ask cystic fibrosis on the test. You've got to know this. So some thought processes around cystic fibrosis. Cystic fibrosis, genetic disease, affects the lungs, mucousy lungs, going to have to go into the hospital rather frequently for checkups and tune-ups, as they call them. Major antibiotics, major chest PT manually or with the machine. Think about what you would do safety-wise if a kid was in chest PT. You would offer them a snack after, not during. When the child is being in the machine, is not the time to give them crackers, so they choke. Okay? Look at how they're trying to trick you. The 6-foot rule. It's genetic. You're not going to spread it to other people. It's not an infection nightmare. Pulmonary function tests. They're playing off the word pulmonary. You're going to see pulmonary and say, yep, that's it. You see what I'm saying? They are not asking you about antibiotics that the kid needs to be on. They're asking you about how to move secretions. Chest PT. What's the other thing with cystic fibrosis you need to know? Pancreatic enzymes. They take pancreatic enzymes before every meal. They don't have the enzymes to break down. Okay, chest PT. Pulmonary function tests are actually, you blow into the meter and it tells you how much volume you have in your lungs. The nurse is taking care of a pediatric client diagnosed with PKU. Which diet is appropriate for this child? So if I did not know anything about PKU, I'd look at this question and say it's either folic acid or protein. What happens with folic acid? Their spine. That has nothing to do with PKU. What's PKU? PKU is that they do not have the amino acid to break down protein. So if they don't have the amino acid to break down protein, why would I want to give them more protein? Thought process. PKU is on that test with 5 little blood drops. It's a genetic test. It's a protein processing disorder. So they end up on special formula if they are formula feeding. If they're breastfeeding, they can stay on breast milk, but eventually they're going to need to go to protein formula instead of milk, because you then won't be able to handle milk with that amount of a protein in it. Okay. Question 6. The nurse is caring for a 6-month-old infant. Which respiratory rate alerts the nurse to a potential problem? Now, on this one, a potential problem would mean look at the numbers and take out the middle two, because the larger one and the smaller one is probably a problem. Which respiratory rate alerts the nurse to a potential problem? So I take out 44 and I take out 56. So I'm stuck between 44 and 22. What do I know is the normal respiratory rate of a child 6 months old? So if I knew that was 30 to 60, now I can get rid of 3 answers. So the 22 is going to be the problem. If I'm not breathing more than 30 a minute, what is going on? 22 would not be good. That's hypoxic. But did I see 6-month-old? Or did I just see 6 and keep moving? That's how they try to trick you. So a normal 30 to 60, 22 would be a cause of concern that I would need to call the doctor after I put on oxygen. There's usually something you can do before you call the doctor. So question 7. The parents of a 24-month-old toddler asked the nurse about age-related developmental matters during a well-office visit. Which practice can most 24-month-olds participate in effectively during mealtime? So I'm looking at this and I'm saying, okay, 24 months, toddler, exerting independence, blah, blah. Which one of these would I want my child to do if they were already 2 years old? Think about cup. Should they still be on a bottle or should they be on a cup by now? Thought process. Would I allow them to pour liquid into a cup? What do you think their grasp and their proprioception is at that age? Cutting with a child-approved knife, eating with a fork. Do you think that they can do that? Thought process. Or is the 2-year-old that you see at the diner banging his fork and knife? So at this rate, you would kind of look at what's the lowest common denominator here? What could any 2-year-old do? Hopefully they're drinking from a cup by now. Eating with a fork, pouring into a cup, and cutting is usually a little later in child development. But that 24-month-old better be drinking by themselves with a cup by now. They should not be still on the bottle. Okay. So the nurse giving care to an infant client reads in the chart to find a history of intussusception, which is a contraindication for which of the following vaccines. So you can take this a couple different ways. Intussusception, if you know what it is, the S's are telescoping on each other. So it's at the ileocecal joint where the large intestine meets the small intestine. And because of that high pressure here and the low pressure here, the small bowel gets sucked up into the large bowel. So it's got something to do with the bowels. Does that help you out? So if a kid had a history of intussusception, the rotavirus would be the one that they could not get. Intussusception involves bowel blockage, bowel ischemia. A history of intussusception is higher at risk of getting an intussusception again after a rotavirus vaccine. All the rest, that's lungs, right? That's not. Okay. This is the only one that has to do with bowels. All right, question 9. A male toddler, age 2, is brought into the ER after swallowing an unknown number of aspirin tablets 30 minutes beforehand. The nurse enters the exam room and the toddler is sobbing and clinging to the mother. Which information should the nurse acquire first? Thought process. Age 2, swallowed aspirin 30 minutes ago. 30 minutes ago. Where are they? If they're not in the stomach, they're certainly on their way. Stomach and the acid, acid in the stomach, stomach and the acid, acid in the stomach. What would that cause if the aspirin's already being broken down? This would be an aspirin intoxication. Bring it back to me. Bring it back to me. What's an aspirin intoxication going to cause? So, information should you acquire first? What's the very first thing you do? Assess. What am I assessing for? What am I assessing for? What am I assessing for? What is my ABG gonna show? This is not about bleeding. Bleeding's gonna come later. This is all about ABGs. Aspirin overdose? Is he gonna be hyperventilating to blow off that extra acid? Ventilations? Just ABC, I want a set of vitals on my patient. ABC. What's he in? Respiratory. Know your ABGs. Know your ABGs. Salicylate poisoning, intentional swallowing or accidental overdose, metabolic imbalances. Symptoms will occur in 3 to 8 hours. Depends how many he swallowed. Okay. At what age should an infant be able to pull themselves up to standing? Thought process. So when I look at this, they're probably trying to trick me with the 2 outliers. So I'll take away the 6 month, I'll take away the 18 months. What do I know? What do I know? 6 months, he's probably crawling. 12 months, he better be starting to walk. At least trying to walk. But at 9 months, if he went from crawling, rolling over, usually the next thing is standing. So pulling up on something to stand up. 9 months. If standing is not seen after 12 months, the child should be evaluated. Okay. So these are those kind of questions that I was talking about. At what age can an infant begin eating solid foods? Throw away 3 and 9. Generally, they're trying to trick you if you did not know the answer. 4 months seems a little early. At 6 months, soft foods can start being evaluated, right? Brought in one at a time. So no longer just breast milk or bottle, but now I can add the other stuff. Rice cereal, things like that. Okay. So solid foods shouldn't be introduced before 6 months. 6 months, I want to keep in your head. Think about it. At 6 months, I start getting teeth. I go to the first dentist visit, and now I can start eating some foods. One at a time so that I know what I'm allergic to. Okay. Sorry about that. Question 12. An audible click when the examiner slips the femoral head forward. Which one of these signs? We talk about scarf sign. That's part of the Ballard. So that can't be it. That's the scarf. That's his arm. That's not right. Babinski, we know, is the toes flaring. The toes flaring is not it. So it's got to be one of these two, right? Or a Lonnie sign for hip dysplasia. This one is for suspected meningitis. So that's not going to get you anywhere. All right, couple more questions. Instructing proper care for their 7-year-old son who's been recently diagnosed with a seizure disorder. All of the following except. So this could easily have been a select all that apply, right? You know seizure care by now. Move the furniture out of the way, stay with them, note the length of the seizure, right? But no object is to be placed in the mouth. Pad their head. You know this. You know this by now, right? Okay. So this one, a little trick here. Here's the problem with this one. The nurse cares for a 2-year-old whose mother is worried that he's not fully toilet trained yet. The mother is worried that he is not able to hold his urine for more than a couple hours, but is proud that he can use the toilet for bowel movements. So, thought process, these are all saying the same thing, right? Bladder control, bladder control, bladder control, bladder control. Okay, so let's read through them. Bladder control usually is achieved after bowel control. Can take anywhere from 2 to 3 years to fully achieve. Does that sound therapeutic? You should tell your son no every time he wets himself. That's not therapeutic. Let's get rid of B. C. Bladder control is usually achieved before bowel control. Wait, that said after. This says before. Wait, bladder control is usually achieved after bowel control. Ooh, ooh. So now I've got before or after, before or after. So let's look at this one. Your child could be developmentally delayed and should be referred to a pediatric psychologist. Ooh, that doesn't sound too therapeutic. So now I have A, C, E, should be fully potty trained by this time. I see a bunch of shoulds. Should you ever should on a parent? In kids, are they always going to meet the same marks as everybody? Are there premature kids that might not be there yet? So looking at that, but he should be fully potty trained by now. So is bladder before bowel or after bowel? Do kids wear pull-ups? Do you give them peanuts, peanut M&Ms to get them to poop on the toilet? So then you're between C and A. So you got to know which one comes first. Is A more therapeutic? He's on track, but it can take longer to get bladder control. That's why he's wearing the pull-up. Okay, so bladder's gonna come a little later. Toilet training can be achieved anywhere from 24 to 36 months. Could take longer in boys than girls. It was a boy. The test question was a boy. There's your boy versus girl. Bladder control usually occurs after bowel control. Should not be concerned if it takes the full 3 years. Toilet training that takes longer than 3 years is probably caused by psychological factors. A nurse should not encourage the mother to tell the child that his behavior is unacceptable. Okay. All right. Think about that. That's kind of how that goes. And then you've got uh, you're doing a little question and answer meeting for the parents, and the parents are dealing with scarlet fever in the community. What do you know about scarlet fever? So which of the following would the nurse confirm is false? Which of the following means it's not a select all that apply? Okay. So scarlet fever is caused by strep A streptococcus. It's transmitted through the air. So children that are sensitive may develop a rash, but some might not. And under the age of 2 is rarely seen with this disease. Scarlet fever is a bacterial infection. We'll come back to scarlet fever in a couple questions. A mother brings her 7-year-old daughter to the ER after she fell riding her bike. Okay, riding her bike, fell, not wearing a helmet, she hit her head on the asphalt. So what would be an early sign that I would see? Which of the following is not a sign of late stage increased intracranial pressure? So if I was bleeding in my brain and I had extra fluid in my brain, what might be the first sign that I see? So think about neurologically how this disease progresses. Intracranial pressure. What's the first thing that I might see with intracranial pressure? More fluid in the head. So later signs, diminished level of consciousness, bradycardia, fixed dilated pupils, late signs. But one of the first signs that I might see are dilated veins on her scalp. Lots of extra blood in the veins, intracranial pressure, right? Think about it like CHF. At what age does the posterior fontanelle close? Which one would that be? Would that be up here, the diamond? Is this one a diamond? Think about it. This one's a triangle, posterior. When does that close? When does that posterior close? Is it first or last? So I probably can take out the oldest and the youngest because they're probably trying to trick me. So if I were between 8 and 12 weeks, what sounds right? 2 months. So somewhere between 6 and 8 weeks that closes. So 8 is the right answer. On a 3-day-old infant diagnosed with hyperbilirubinemia, a bilirubin test is required by capillary heel puncture. The nurse does all of the following except. So go through these and say true, false, true, false, true, false. If you do not know about a hyperbilirubinemia heel puncture, just consider it like a blood glucose. So squeezing the infant's heel while collecting the sample. Turning off the bilirubin lights. Apply an antiseptic wipe to cleanse the foot. Sounds plausible. Wiping away the first drop of blood. Sounds plausible. Applying heel warmers to increase blood flow. Sounds plausible. So let's go back to A and B. All of the following except. So do I turn off the treatment lights before collecting the sample? Yes or no? Or do I squeeze the infant's heel while collecting the sample? Which one sounds right? So knowing what the Billy lights do is important here. The Billy lights are going to continue to break down bilirubin if you have them on. So as you're collecting the sample, it continues to get rid of the bilirubin in the blood. That's why the tubes are usually brown in color to hide it from light, and you put it in a brown bag to send down to the lab because any light is going to continue to break down bilirubin and affect the results. So you do turn off the lights. That means you really don't want to squeeze the baby's heel. Squeezing is going to cause hemolysis. It's going to break down. Okay? The other thing is too much pressure. You're going to cause a big black and blue on that kid. You don't want to do that. Okay. Here's an APGAR question. So put up your 10 fingers. Newborn infant, vigorous good cry. A heart rate of 97. Good reflexes. Acrocyanosis. What can I take off for? 10 up. Vigorous cry. I can't do anything about that. That's good. A heart rate of 97. Is that under 100? 1 down. Good reflexes. Is there anything wrong with that? Acrocyanosis. Oop. All right, I got 8. All right. Which of the following would increase suspicion of strabismus in a pediatric patient? What is that one? If I don't know what that word is, I'm going to be in trouble. So if I absolutely did not know, right, I could always, don't freak out, take a deep breath. Okay. The child does not respond to loud or sudden noises. I think that's hearing. The child consistently squints or tilts its head to see. See? Okay. The child complains of frequent nausea. I'm not sure. Difficulty holding eye contact. Oh, okay, so that must be something to do with the eyes. Oh, yeah, I remember. It's cross-eyed or a lazy eye. Okay, now look at it again. So now I know it's cross-eyed. Which one would they do, B or D? So this one, responding to social clues. What? Hold on. Holding eye contact or responding or means and. Oh, I don't think they have social issues. They just can't see. So squints and tilts his head to see. It tells you the misalignment of the eye and one's becoming dominant. So they're constantly looking. Okay. Responding to social cues would be potentially hearing. Hearing. and it has nothing to do with nausea. Okay, number 21. Here's your stuff again. Strawberry tongue and maculopapular sandpaper rash. Sandpaper rash. Well, varicella is chickenpox. That's not sandpaper. And patago is usually around the mouth. Usually honey crusted blisters, hand, foot, mouth disease kind of thing. So I'm between roseola and scarlet fever. Oh, darn, there's that scarlet fever again. So that's one of those that you just got to remember. Strawberry tongue. So their tongue literally looks like a strawberry. Glossitis. And sandpaper rash. Sandpaper rash. You're looking for maculopapular rash. Looks like sandpaper. Okay, just something you need to know. It's often after strep throat because it's strep A, right? All the rest, not big on it. That's not it. All right, at what age should an infant have doubled its birth weight? Again, if you heard me before, there's something about 6 and 12, 6 and 12, 6 and 12. There's something about 6 and 12. At what age should the baby have doubled his birth weight? Double by 6, triple by 12. Double by 6, triple by 12. There you go. So, just like I tell them, always ask yourself, does my answer choice make sense? Or how are they trying to trick me? How do you know your answer is right? Justify the other ones are wrong. Plausible? No, that sounds stupid. Talk to yourself through the test. Does your answer choice answer the question? Always go back up and make sure that you answered the question they asked because they love to give you a distractor to get started thinking on about anemia, but it has nothing to do with anemia. Make sure you're answering the question. Some test taking strategies. The test taking strategies that I've gone over will help you correctly answer the question and support your understanding of the rationales. So the biggest thing that you can do is practice, practice, practice. Go in and do those Learning Systems 3.0. Do all the practice questions you can on the Peds. Care of the Children is the worst of the two ATI tests. So the more questions that you can potentially do, the better you have the chances of getting that level that you need on that test. All right, talk to you later.